I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChinMed needs physicians to take care of them. Tonight's topic is orthopedic problems in primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan. How are you doing tonight?
Hey, Faisel. It's great to be with you.
It's great to be doing this last live episode with you, Dr. Dan. It's been such a pleasure doing this. I mean, I never would have thought when we first started doing all this that it would become what it's become today. But
yes, but I agree. But we don't want anybody to be confused. We will still be doing these, and the podcast will still be available for people who want to listen to our guests.
Exactly. The audio is what people want. They don't want to see our faces on here. So it's been a fun ride while it's lasting. So our guest for this evening is Dr. Brian Gordon. Dr. Gordon, thank you so much for joining us this evening.
Well, thank you both for having me. I'm excited for our discussion.
Me too. I mean, so I remember from medical school and residency, there's always we're seeing different kinds of musculoskeletal issues on a day-to-day basis in the primary care setting. I remember in residency when you had the time to be able to do a proper evaluation and to offer different treatments. But gosh, when the schedule gets tighter and tighter and you're just kind of just running through, you find yourself, inappropriately referring out. I remember that years ago, and we see that so much today in the fee-for-service system. But before we get into all that, I'd like to, of course, you're an orthopedic surgeon working with a primary care delivery organization. I'd love to hear a little bit about your story.
So yeah, it's very different from the last 27 years of my life. So I ended up, going to, I'm from upstate New York. I'm from outside of Albany, and I didn't really venture too far from home. I went to college at Colgate, where weather's awful cold there. And from there, ended up in Syracuse for medical school. So I certainly didn't head to the tropics. And I stayed on in Syracuse from orthopedic residency. It was a phenomenal residency program. And then did my spine fellowship. I'm board certified in orthopedics, but did my fellowship in spine at the New England Baptist Hospital, part of Tufts. And that was in Boston. And then went back home. My wife and I are both from the Albany area. So we wanted to go back home and raise our kids near our parents. We had the benefit of living near our grandparents, and we wanted that for our children as well. So I entered a large orthopedic group. I was the only spine surgeon, and I was taking general call as well as spine call. And whenever an orthopedic group gets a spine surgeon in, it seems like everybody's brain is erased in how to handle anything that has to do with back pain. Oh, that's the spine guy. So, orthopedic surgeons are really no different than PCPs. I know my friends that are PCPs, they can judge how good or bad their day is going to be very often by looking at how many low back pain patients are on the schedule.
Yeah.
So I was a partner for 7 years, and I found that I had a lot more in common with my neurosurgical colleagues in a lot of ways, and ended up joining 3 neurosurgeons, and we built a spine center.
Wow.
And it was very comprehensive. And in the Albany area, we were the only group to combine orthopedics and neurosurgery for spine care. And we were really a one-stop shop in a lot of ways. We had our own x-ray, we had our own MRI, we had our own fluoroscopy suite. So we could actually see someone, get an x-ray or an MRI if needed, and do an injection. For instance, they had a disc herniation the same day. And our catchment area was very large. We went up to the Canadian border,
Wow.
to Western Massachusetts, down south, close to halfway to New York City, and out west to Utica, so almost near Syracuse. So,
Wow.
it was very beneficial for a lot of patients. But what I found after doing this for about 21 years, 22 years, I was seeing a lot of patients. I was managing our practice. Between my nurse practitioner and I, we'd be seeing anywhere from 12 to 1,400 new back pain patients, neck pain patients a year, plus rechecks, surgeries, and the like. So I really started to get burned out. And one of the things that really burned me out was, quite frankly, and a lot of orthopedic surgeons or spine surgeons and neurosurgeons would say I'm a heretic, but there was so much unnecessary surgery being performed. And we were getting the fallout from that. Our group we were getting a lot of second opinions from patients who had failed surgeries before. And, day after day of telling patients, there wasn't anything that you could really do. And a lot of times the patients were worse post-operatively than they were pre-operatively because surgeries that quite frankly weren't indicated. It just became very difficult. So I was really getting burned out, but I still felt, at least I was relatively young at the time. I was in my, it was just a couple of years ago. April of 2020, I decided, I talked to my wife and said, well, I'm really not happy with work. And what else can, I feel like I have gas in the tank left. And I became the medical director for New York State Workers' Compensation, which was completely different than anything I had done. And remember, April of 2020, COVID was really just smacking us in the face. And I worked with the lead attorney at Workers' Comp, and my biggest concern was we were going to have a lot of workers that were going to have COVID, and we had no protocols in Workers' Comp for all of New York State, nothing to deal with COVID. So we designed all the protocols and procedures for COVID, redesigned the orthopedic basically pathways for Workers' Comp. And ChinMed found me, and I told them, look, I just got this job, I'm really happy. I transitioned out of clinical medicine into this administrative role. I really like it, blah, blah, blah. I'm not interested. And then lo and behold, I'm on Faisel and Friends talking to you about my experience, right? So I love the idea of, our core model and our mission of taking care of those who need our services the most. I love the idea of VIP care for quite frankly, patients who may never have had a doctor or haven't had a doctor in 30 years or 40 years. And, this is work that other people just don't want to deal with. Yeah. And, we're running into the fire. So, it was intriguing. And, I started with Chen in October of 2020, and it has just been a great experience. October 2021.
Oh, well, thank you so much for sharing your story. It was very deeply personal. It's very intimate. Oftentimes we talk about, in healthcare delivery, we're always, and most of the time, you're not dealing with black and white situations, and there's always the gray space. And when you're in a system where there's just so much inefficiency, maybe it's a good decision for the patient, maybe it's not the best decision for the patient. And then when you have to deal with, now we have an entire system that just deals with the consequences of not making perhaps the best or the most efficient decision for each individual person. And once you start to lose that feeling of fulfillment, especially when we're talking about medicine, it's a bad place to be in. And thank you so much for sharing that. It's very brave of you.
Well, I think it's important for people to be true to themselves, and you can't, as you're saying, you really can't do a good job, especially in a job where people's lives depend on it, if you're not enjoying it.
Yeah.
And I think that's important for people to understand. You got to love this.
Right. So you brought up, it's interesting you brought up the unnecessary surgery, because I bet nobody who ever goes through an orthopedic residency or goes through a spine fellowship starts with the idea, hey, I want to do unnecessary surgery. Right? I mean, that I think we all go into careers to help people. But what do you think it is about the healthcare system that leads to the unnecessary surgery? Because I'm assuming good people don't just decide to start doing unnecessary procedures. There's got to be something that leads them down that road.
So Dan, I think, you're begging, you beg the question, what happens, and we know the answer, right? Spine surgery, look at orthopedic surgery and spine surgery is what? It's lucrative. And spine surgery can be very lucrative, right? You start to do multi-level instrumented fusions, and you start to live large, and it can become a monster that needs to be fed. And I think that no one in their medical school interview said, yeah, I want to go into this because I want to make a lot of money. But unfortunately, some things happen, and I do think that the fee-for-service world can breed that. And I'm certainly not condemning my colleagues with a broad brushstroke, but I do think that sometimes we can deceive ourselves in thinking that we're doing the right thing, but it may be for the wrong reason and not realize that. I think we talk about the prevalence of musculoskeletal conditions.
Yes.
And when you realize that half of adults in the United States are affected by a musculoskeletal condition, and 3 out of 4 people over 65 have a musculoskeletal condition. I mean, these numbers are staggering. I mean, this is more than patients than circulatory problems. It's twice the number of those of pulmonary problems. So, it's out there, and we all know, look, everyone's had a friend who's had a knee replacement or a hip replacement, and they're like, oh my God, this is the greatest thing that's ever happened to me. But we also have to realize that those are selected patients. It's not for everybody, right? When we think about, it's interesting, there was a Swedish study that showed that 29% of the patients that saw a PCP doc at any one time were complaining of musculoskeletal problems. Now just think about that, right? And if all those patients get, funneled directly to an orthopedic surgeon, well, what's going to happen? We're going to get a lot of unnecessary testing. We're going to get a lot of unnecessary procedures. So it's what I've seen at Chen, and I think is really important, is that the PCP can be a prime gatekeeper in terms of, hey, who is the right patient that really should be sent out for that procedure? We're not here to prevent our patients from getting appropriate procedures, but we are here, at least in my mind, we're here to provide that VIP care, right? And that VIP care is making sure that the right patient goes to the right surgeon for the appropriate procedure at the right time. So,
yeah, I'd like to, just the philosophy is, the primary care doctor, the healthcare delivery team, when you have everyone on board feeling responsible for the outcomes of the patient, for the health outcomes of the patient, you're protective of your patients, and we know the patients don't know what they don't know, and there's so much misinformation. There's so many that it may just say, okay, it's a joint problem. Go to the bone surgeon, and if the doctor if the primary care doctor is seeing 30, 40 patients every day, thousands of patients on the panel, and maybe you have one or two conversations with the patient, okay, put in the referral to go see the orthopedic surgeon. But like you said, when the numbers are just so staggering, of course, that's why we end up having the system where you got 1 million doctors in America, and only 20% of them are primary care doctors. 200,000 primary care doctors, 800,000 specialists. We've got a whole system that's just upside down.
Yeah.
Well,
I was going to say, I was just going to make a comment and then bring in a question I think you mentioned Sweden, and if I'm not mistaken, I think Sweden has fewer orthopedists doing joint replacements than are doing joint replacements in the city of Richmond, Virginia, with a population of 1 million people in it. So I mean, that's the other thing that's going on. Tracy asked, could you talk about physical therapy versus alternative therapy, such as acupuncture, chiropractic, and even stem cell injections?
yeah, so, we know that for a lot of conditions, physical therapy can be helpful. So we can look at a deconditioned spine, and if we look at our patient population, right? Pretty much most patients are over 65. If we throw all of those patients in an MRI machine, what is every one of those patients going to have? It's the dreaded disease, right? Degenerative disc disease, right? Everyone's going to have that. And, the patient sees this, oh my God, I got this disease and it's affecting like almost all my discs. What am I going to do? Well, those patients with back pain, most of the time they're deconditioned. And if it's a primary complaint of axial back pain, we know that most of those patients are going to get better with conservative care, including physical therapy, right? Acupuncture certainly has a role. Now, we found that when we look at the recommendations from the American Academy of Orthopedic Surgeons, acupuncture for knee pain has not been proven effective. So it's not recommended. However, it can be effective for patients with back pain. So those are perfectly reasonable, but you have to tailor the treatment to the diagnosis. And a lot of times, this is where we run into a problem. We oftentimes jump to the treatment before we actually have a diagnosis. And in musculoskeletal conditions, we do that a lot. Probably more than, we're not sending people for chemotherapy before we diagnose their cancer. So in musculoskeletal disease, it's really not fair just to say, all right, well, we don't really know what you have, so let's just send you physical therapy. The history and physical are so important. And it does, Faisel, you mentioned, it does take time, right? It does take time. But if you listen to that patient and you hear them out and you ask the proper questions and you do a real exam, you'll come to the diagnosis. And I would venture to say that 80+% of the time, probably 90%, the initial treatment that should be started should be done by the primary care doc. And it's done safely by the primary care doc. You did mention stem cells, and that is something that raises the hair on the back of my neck like nothing else. There are really no good studies, randomized, controlled, good studies that really supports the use of stem cells. And I pose this to you. We talk about stem cells, right? And we talk about, most people are talking about cells that are spun down from whole blood, and we're injecting them. Now, how does the same spin down that the dermatologist uses to grow hair, okay, that the spine surgeon uses to augment their fusion, and the joint reconstruction guy talks about as growing cartilage? This is magic. This is Harry Potter. This is what? So I am really, as you can guess, I'm an anti-stem cell person at this point. We don't have the knowledge and we don't have the scientific backing yet to recommend these procedures or have the conditions that to really know what they're warranted for, if they're warranted for anything. And people don't think about the other side of this coin. We don't know if and there was an article in Seminars of Spine Surgery that talked about stem cells several years ago. And one of the articles talked about, could these spins and could these injections actually be tumorigenic? We don't really know. And the right person who may have some abnormal cells, we don't know what these are really going to do. So I'm not at a point where I recommend these, and I personally don't believe in them, because it's could be 21st century snake oil. I don't know. I'm not buying it.
Right. And I've got to say, I like that. Asking for proof before you do it is important. And it's not really a matter of what you or I believe. It's what the evidence would show us. And right now, the evidence is not there. So we have another question. I'll bring in one more if that's okay. Stefan Gonzalez from the American Orthopedic Partners is asking, what is important for ChinMed when referring out to external independent orthopedic practices? And I know part of your job is to help us figure out who we should be referring to. And so you're guiding us there. So would love to know what your thoughts are about that.
So I have to be a little careful here, because I can't give away the secret sauce, right? So I've been on a mission for the last about 4 or 5 months, developing some algorithms with our computer folks. Look, I'm an orthopedic surgeon. I'm much more of a stone tablet and chisel guy than a computer guy, and I'm not ashamed to admit that, right? So, with the help of our computer folks, we've been working on some algorithms to help us identify, utilizing our historical data, and some of what I hope is knowledge on my part about, hey, what makes a good orthopedic spine surgeon? What makes a good orthopedic joint surgeon? What makes a good orthopedic hand surgeon, et cetera. And we've developed a tool to help us actually utilize our own data to choose the best docs in each orthopedic subspecialty. So we are actually doing that in each of our markets at the present time. In fact, for orthopedics, it's all pretty much done, but we're doing this for all of our subspecialties as well, our other specialties as well.
Okay. And I don't know what went into the algorithm, but we do a lot of IT, but it winds up being pretty simple at the end. We basically are looking for doctors that will treat our patients the way we would want our own family members treated if they went to those doctors, and will communicate back with our doctors about what they're doing. We want to be able to. I know I, as a PCP, want to be able to have an intelligent discussion with the specialist, and I want them to recognize that maybe I know more about the individual patient. I don't know as much about how to do the surgery, but I might have a good idea for what kind of support systems they have at home, what the family can and can't get through, and have a discussion. And if somebody doesn't want to have that discussion, I don't want my patient seen, though.
100%. And I will tell you that a lot of what we've devised, what I've worked on, is outcomes driven. So we have looked at the outcomes from our joint reconstruction surgeons, our spine surgeons, our hand surgeons, and we have algorithms too that I've helped develop to really help rank them, quite frankly.
That is wonderful. Yeah, we talk about often the time that doctors need to properly evaluate some of the common conditions. I saw in one of the questions here, you think about your typical fee-for-service practice, primary care practice. One of the questions was about, what are some of the value-added tests and procedures, exams, when specifically dealing with some of the common shoulder and knee complaints?
So this is really a good question, and we're unique at ChinMed because we have the ability to spend a lot of time with our patients. We do not have to, herd cattle and get, 30, 40, 50, 60 patients in a day. And, nobody went into medicine thinking that was going to be, it wasn't going to be a race, okay? This isn't the medical Olympics where those who can get through fastest get the gold medal, but in the fee-for-service world, it kind of is. But, so what are important? What are some take-home things? So when I talk to RPCPs, and if any of our PCPs are on here, they're probably going to vomit because they hear me say this all the time. So let's look at shoulder pain. Okay. That Swedish study talked about like 1/3 of adults have shoulder pain. Okay. Whatever it is, it's a lot. So I'll pose a question. So amongst 70-year-olds, what percentage of 70-year-olds would you think have rotator cuff tears? What would you guess?
You mean if you actually did the MRI?
Yeah. What percentage of 70-year-olds have rotator cuff tears?
Oh, God. I would guess 30 to 40%.
Close. 50% of 70-year-olds, right? What percentage of 80-year-olds do you think have rotator cuff tears?
Then that's going to probably be 70%.
No, this is like the perfect orthopedic number. It's 80% of 80-year-olds. Even orthopedic surgeon can remember that. Right? So 80% of 80-year-olds, right? So when we have someone that comes in with shoulder pain, should the first test be to get them an MRI? Absolutely not. Because we have a pretty good idea in our patient population what that's going to show. And do orthopedic surgeons operate on 50% of 70-year-olds and 80% of 80-year-olds? Well, I certainly hope not. Okay, so what can we do? Well, we want to get an idea of really what's going on. And it gets back to that history and physical, right? Well, when does that shoulder pain bother the patient? Is it when they're, stacking cans, putting the green beans up into the counter, into the cabinet? Is it rolling over in bed? Because if it's those kind of things, well, that could be rotator cuff disease, right? Of more concern, is this something that's a gnawing pain that is constant and associated with weight loss and maybe the history of cancer or something? Well, that's a different story, right? So we've really got to look at the history, and then we got to do the exam. What's their range of motion like? Do they have any pain with provocative testing? Do they have any weakness? Is this really their shoulder? Could it be coming from their neck? So these are the things that I want to talk about and engage PCPs that we work with to think about these, as opposed to, we have to get that diagnosis before we start ordering tests and treatments, right? So is it reasonable to get an X-ray in someone who's had persistent pain? Yeah, it's reasonable. Want to make sure, especially if there's anything that you may be worried, could there be a bone tumor here, a history of cancer, anything? Put your mind at ease. An X-ray, that's simple enough. I don't worry too much about that. Should we be running to get an MRI on these patients? No, because even if the MRI shows a rotator cuff tear, and I'm not talking about like an acute traumatic event, but I'm talking about the run-of-the-mill degenerative stuff. The initial treatment is going to be conservative. So what can we do? Well, that's an ideal opportunity for physical therapy, anti-inflammatories if tolerated by the patient, acetaminophen, and if that doesn't work, do a subacromial injection. You don't have to send to the orthopedic surgeon, rheumatologist, or pain management doctor for a subacromial injection. Your patient satisfaction scores will go through the roof. If you tell the patient, hey, I can take care of your pain and give you a shot today, save you that trip to the orthopedic surgeon that'll probably be 3 weeks out anyway, and the co-pays and everything else associated with it. So these are all things that we can do. And the orthopedic surgeon is going to love you because, quite frankly, he doesn't want to see that. He wants the patient that fails those treatments and is already been worked up and ready to go for surgery should they need it. And the same holds for knees, right? When we look at knees, we know our patients are going to have degenerative changes, and part of degenerative change of the knee is going to include meniscal tears. So we don't need an MRI to know that our 65 or 75-year-old patient's going to have meniscal tears. They all have those. But we do know that arthroscopy and medial meniscectomies for degenerative arthritic changes in the knee are not successful surgeries.
Absolutely. I mean, I was at a meeting a few years ago with a bunch of the younger doctors in our company, and somebody was saying they were so thankful that they had their knee had hurt every morning for 2 weeks and it had quit hurting. And at my age, it's just a matter of which. It's not if a joint's going to hurt in the morning; it's just which one's going to hurt in the morning. And it's going to get better if I just get up and go about my day, and it gets better.
Exactly. And we know that, like for the patients that have knee pain and knee arthritis, we know that first line treatments, again, recommended by the American Academy of Orthopedic Surgeons, Rheumatology Society, et cetera, physical therapy, anti-inflammatories if tolerated, and in-office injection by the PCP, your patients will love you. They're going to love you.
So, Faisel, do you want to do your message?
My goodness, it's already been, we're already at time. So let's take a quick 20-second commercial break, and then we're going to come and wrap things up with our National Director of Orthopedic Surgery. Thank you so much, Dr. Gordon. This has been great.
ChinMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chinmed.com/physicians for more information.
And we're back. It really is only just 20 seconds. Dr. Gordon, now you've come on board as our National Director of Primary Care for ChinMed. For those of you listening who don't know about ChinMed, ChinMed is a full-risk primary care delivery organization. Our doctors don't do billing. They're not concerned with billing. They're focused on taking care of patients. And so in our model, we have access to specialists like Dr. Gordon without even needing to do a formal consult. So Dr. Gordon, I'd like for you to share a little bit about your experience working in this type of environment where you have primary care doctors calling an orthopedic surgeon like yourself, like a phone a friend or even curbside.
So it really is, lots of curbside consults, discussions, et cetera. And it's reminiscent of, I'm a little bit older than you, I think, Faisel. So, but when all the doctors went to the hospital, you oftentimes saw people in the hallway, and you'd say, "Hey, I got this interesting case. What do you think I should do about this?" And this is what we do daily. So I've been keeping tallies, and I know the other specialists have too. How many interactions, primary care specialist interactions have I had? So I started really logging them in earnest on July 19th, and I'm approaching 1,300 PCP interactions since July 19th.
Wow.
So I'm accessible via our internal GLIP system. I'm accessible via our cell phone, email, basically anything short of a smoke signal. The PCPs can get in touch with me. And, I'm one of those guys, I stay up late. I believe there's plenty of time to sleep when you're dead. So, it's not uncommon for me to be answering some questions at 12:30, in the morning, 11:30, sometimes I guess I never got off those resident hours. So, and the other specialists are doing the same thing. And when you think about the number of specialists that we really have a real complement of services in our arsenal available for those PCPs that have questions. So you got an endocrine question, you got an endocrinologist, you got an orthopedic question, you got me, you got a pulmonologist, you got vascular and general surgeons. We got specialists coming out of the woodwork. So, and we're there to help. So I hope that we make the PCP's job easier, because that's really what we're here for. And we're here to provide that better care for our patients.
Yeah, but I would say we have about 400 doctors working for the company, and that probably includes you. But the 1,300 probably means your average of each PCP's asking you 5 or 6 questions during that period of time. So, I wouldn't want somebody listening to think that we handcuff the PCPs that they've got to ask the specialist. We don't do that. But boy, I know you helped me out. I had one of my patients that was bedridden. She had what was pretty clearly a humeral fracture, and it was going to be really difficult for the family to get her to the orthopedist. And you gave very good advice about what we needed to be looking out for and what we needed to be doing. I was able to reassure the family. And yeah, she wound up seeing an orthopedist, but she didn't wind up getting an unnecessary operation, which but, I had the information you gave me in my back pocket before we had that conversation, and I was able to advise them what to watch out for. So, yeah, I mean, it's really cool you've answered that, but we've got a lot of doctors, so it's not some huge number by each doctor either.
Yeah, and I would add, Dan, having us available allows the PCP, no one's forced to call me. You're not forced to talk to me. But should you want to, you can go back to the patient and say, hey, I spoke with our in-house board certified orthopedic surgeon, and, your mom has an inferior pubic ramus fracture. There's no need to send her to the orthopedic surgeon, pay the copay, get the x-rays there, do the follow-ups, and incur that expense, because he's not going to do anything different than I'm going to do, because I just got told what to do by the in-house guy. So there's a lot of times where we can save the patient time and money and provide really that VIP care through our own in-house PCPs.
It's along the lines of so much that we see in the healthcare delivery for seniors and really our patients at large. It's not that we focus only on unnecessary hospitalizations. But that is a big driver right now with the waste, is unnecessary hospitalizations. And so we're not an anti-hospital organization. We just want the hospitals to do what they need to do and nothing else. And the same thing goes with any of our specialists as well.
Exactly. And, as I said before, I'm not here to push that big red no button. I'm here to make sure that we get the right person to the right surgeon for the right procedure at the right time. And, there's been many times where we've had patients with severe knee or hip arthritis, and they are, from x-ray standpoint and from a pain standpoint and loss of function standpoint, they're candidates for a joint replacement. But their hemoglobin A1C is 11 and their BMI is 48. It's not safe to do that operation on them. The risks are too great. And that's where, as a PCP, you can say, hey, I talked to Gordon. He's our orthopedic surgeon, and it's just not safe to do this until we get your medical conditions under better control. Let me be the bad guy. I can be the bad guy. And so that's a service I provide. I'm the bad guy service.
You're the bad cop. Yeah,
exactly.
That works in our home too with the kids. So, Dr. Gordon, thank you so much for joining us tonight. And to our audience as well, thank you.
Thank you guys for having me. And I'm sorry that you had to look at this mug as your last live podcast.
No, this was a great episode. It's one that I've been really looking forward to. Actually, in fact, I'm looking forward to even developing some additional content, especially for residents, for residency lectures. You gave a lot of great examples, and I know you're just filled with so much. I've heard nothing but just incredible things from our primary care doctors who've been working with you. It's reminiscent of the time of, it reminds me of residency in the physician's lounge, where you would curbside the specialist, like, hey, I got this thing going on here. I'm sort of thinking about doing this. What do you think? And, it's nice. It's nice that even now in 2022, we view these as opportunities to build relationships. We're not only restoring the doctor-patient relationship, but we're also restoring the doctor-to-doctor relationship. So thank you so much for what you do for ChinMed, and thank you for joining us tonight.
Thanks, guys. Thanks for having me.
To our audience, for more information about tonight's topic and to explore career opportunities with ChinMed, please visit chinmed.com. We believe access to primary care is a right, not a privilege.